Good morning. This is Dr. McDaniel. It's Tuesday, May 14th, and I'm continuing the presentation on oral contraceptive pills, OCPs, birth control pills. So yesterday I spoke about the fact that there are two types of pills, either combined hormonal pills or progesterone-only pills. Progesterone-only pills are taken by women who either cannot tolerate even the most minimal side effects from estrogen, or who for medical reasons are not recommended to take estrogen. And that would be because they have cardiovascular disease, or such as heart attacks, strokes, deep vein thrombosis, superficial thrombophlebitis, or they've had a history of pulmonary emboli, migraines with aura, or ocular migraines, vascular migraines, or they're breastfeeding. So those are conditions where we don't recommend women take estrogen. It can be detrimental to their health. And the birth control combined pills, that's the most common pill. Even women who are fine with estrogen will sometimes medically not want to take any of the estrogen pills because it is responsible for some of the premenstrual symptoms. Some of the pills can enhance certain premenstrual symptoms for some women. The most common would be menstrual headaches, breast tenderness, breast pain, breast enlargement premenstrually, sometimes nausea with or without vomiting. So those are more of the estrogen-related symptoms. Because all of the pills, like 95% of the pills are low-dose estrogen pills now, nowadays for like the last 30 years or so, it's not common for someone to have estrogen-related side effects. But sorry, every once in a while, someone will have some side effects. And the majority of premenstrual symptoms are due to progesterone. So appetite change, acne, bloating, fatigue, insomnia, muscle aches, flu-like symptoms, emotional, irritable, all of those type of side effects are predominantly due to progesterone. So the combined estrogen pills help balance out potential premenstrual symptoms. The monophasic pills, where the hormones do not fluctuate during the month, they will help to minimize premenstrual symptoms also. And the combined estrogen pills also help balance and prevent the risk of bleeding outside of the menstrual week, or what we call breakthrough bleeding, provided someone's taking the pills every day at the same time. So provided they're taking the pills correctly. Now the only pills we have that are considered high dose, or at least moderate dose, are 50 mics of estrogen. There's only one company that produces that now. It's the overall pill. It's often difficult to get, and we only prescribe that for women who have a lot of issues with bleeding outside the menstrual week on the lower dose pills. All the rest of the pills on the market are considered low dose. They're 35 mics and under. So they go from 35 to 30, 25, 20, and 10. The 10 mic pill is super duper low. So I usually only prescribe that for women who either tell me that they've been on a 20 mic pill and they've had a lot of issues with, sorry, I'm cold this week, a lot of issues with premenstrual symptoms or side effects, or that they still have heavy cycles on a 20 mic pill. Usually if someone doesn't have a history of pills or a history of issues with pills, but they tell me that their natural cycles are 7 to 8 days or 9 to 10 days or even longer, then I recommend the 10 mic pill, because that should on average cut their cycles by about 50 to even 70%. If someone only has 4 to 5 day cycles, the 10 mic pill might be too low of a dose for them. They'll skip cycles, or they'll have bleeding outside of the menstrual week. It's just not a high enough dose to maintain the normal equilibrium of the and stability of the uterine lining. So predominantly, most women are on a 20 or a 30 mic pill. The most popular of all the strengths is 20 mic. That usually cuts the cycles at about 40 to 50% in length, 40 to 50% in flow, and if someone's on it for a long time, which would be more than 3 or 4 years, they will often get super light, super short cycles. Their body maintains a very low level of equilibrium or balance, so not much blood builds up, so not much blood will come out. And most women now all of the 20 mic pills are considered monophasic pills because the pills stay the same hormone level all month. They don't fluctuate. And that's the best pill to take if someone has a history of lots of premenstrual symptoms or premenstrual dysmorphic disorder, PMDD. Sorry. Now, some people ask, well, why do you have 35 mic pills or triphasic pills or biphasic pills if the best pill is the 20 mic monophasic? Well, it's the best for most people. It's not the best for everyone. So some women, the 20, 25, or 30 mic pill is too low of a dose. They're taking it perfectly. There aren't any interruptions. And they're still having bleeding in the 3rd week or bleeding twice a month, bleeding in the 2nd week, bleeding again the 4th week. It's just not a high enough dosage to maintain the stability for their uterine lining. So they need a 35 mic pill. Some women, even on a 35 mic pill, may still have some bleeding irregularities. So then we switch them to a triphasic pill. That induces the cycles a little bit better. Women who naturally skip their cycles, so they only get their cycle every 3 to 4 months or every 6 to 8 months, naturally, they will always do better on a triphasic pill first because it whips the cycle into a regular pattern and a predictable monthly cycle pattern. And then if they're unhappy on it after 6 months or so, they could switch down to a monophasic pill. So those are the large, kind of the big differences between the different strengths and the different modalities. The triphasic, the monophasic. The biphasic is a special category. There aren't very many pills that are biphasic. And that pill was specifically introduced to try to decrease nausea side effects from estrogen, even on these low-dose pills, for a small category or small class of women who have nausea or menstrual migraines during the placebo week. So that pill was induced to give a little bit of estrogen during the placebo week and then cut it off at the very last couple of days. Lastly, of the 20 mic pills, we have all of the pills are 21-day cycles. So you have 21 days of hormones and then 7 days of placebo. There are 2 exceptions to that. The first exception is the 24-day pill. So that's 24 days of hormones and only 4 days of placebos. And that was introduced in order to decrease the pill-free week or the hormone-free week for women also who have side effects during the pill-free week, and it also will decrease the menstrual cycle even more. And then there's the extended cycle pills, which are the pills where you don't have the hormone-free week once every month, so every 4th week. It's once every 3 months, so it's every 12th week. Those are all equally effective for contraception, equally effective for producing the desired side effects that we would like to see. So there are lots of options for pills. All of them work for contraception. We have all of the different types of strengths and modalities simply because we manipulate their side effects in order to get desired outcomes. So I hope that's been helpful. This is Dr. McDaniel on GYN Corner. Please check out the YouTube channel. It's called GYN Corner also. And there it's nice because all of the different presentations are labeled or titled. I know it doesn't look super great. I'm working on making it look a little bit more professional and nice, but I'm just trying to get the information out, so it's what I have because I'm not a super techie person. But I hope it's been helpful. Everyone have a great rest of the day and see you tomorrow. Hump day.